Welcome, everybody. Thank you for those of you who are chatting in your name and organization and something that's making you feel hopeful as you come into this Zoom room. We are not going to go around and do individual introductions because we want to, one, honor that not everybody was able to be here with us today. And so we will be recording this webinar that is announcing the Delta Center for a Thriving Safety Net Phase 2 opportunity for primary care associations and behavioral health state associations, and want to do that in a way that is welcoming to everybody, and also gets the information out as expediently as possible. So do feel free to continue to follow suit if you, with your name and introduction of something that makes you feel hopeful at this moment in time. But I think we're going to go ahead and get started to stay on time. So welcome. My name is Rachel Toby. I am from JSI, or JSI Research and Training Institute. We are a public health research and consulting organization and are delighted to be joined by a number of partners that I will be introducing shortly on an initiative funded by the Robert Wood Johnson Foundation that is called Delta Center for a Thriving Safety Net. Go ahead to the next slide. So our quick agenda for today is that I am going to do my best to first explain what is the Delta Center, to give an overview of the funding opportunity that is available, and of course is in much more detail in the written CFP that has been released, to go through some specifics of the application process, and then also to have ample opportunity for Q&A through the chat, through asking questions, and we will also have a Q&A open for a number of weeks in case you were not here for the webinar or if you have questions that arise afterwards. So, what is the Delta Center? In a few words, the Delta Center is bringing together primary care associations and behavioral health state associations to advance policy and practice change at both the state and national levels. Our ultimate goal with this project and with this initiative is to cultivate health policy and a care system that is more equitable and better meets the needs of individuals and families. It is important that the way that we are doing that is by building capacity and relationships amongst state associations, because we see state associations as a critical part of the safety net infrastructure, inasmuch as associations are oftentimes tasked with advancing policy and regulatory change within their states, listening to their providers and in turn their consumers and patients in terms of what types of care, what types of policy change is ultimately going to improve outcomes and improve lives. Next slide, please. We are also honored and delighted to have a host of strategic partners on this initiative. And I'm going to introduce some of them personally to you and others with hopefully a wave for now, but we are joined with National Council for Behavioral Health, as well as the National Association of Community Health Centers as strategic partners who will be the entities that actually make the grants to their member primary care and behavioral health state associations. We are also honored to be joined by the McCall Center at Kaiser Permanente Research Institute, Washington, and Katie Coleman and her team in particular, as they bring deep and long experience in researching what types of practices ultimately result in better outcomes on the ground for patients and consumers. We are also honored and have a new partner in this phase of the Delta Center in Families USA. I will say that for some of you who have heard about the Delta Center as the initiative that has been going on for the last 3 years, we did not have families at the table the last time, and we are absolutely delighted to have them this time, because one of the shifts that has happened from the last 3 years to the next 3 years is really an increasing focus on how to shape policy change and how to shape care change with consumer at the center, and with the end goal of genuinely changing outcomes and changing experience for individuals and their families, and to also do so honoring equity as both a goal and a practice, a process of involving different voices at the table and consumers in particular at the table. And so Families USA has again, a deep and long history of doing this well. And we are delighted that they are joining us to ensure that both the state associations as well as we as a program team are honoring that commitment and building on their long history of best practices in this arena. And then finally, and of course, not least, Robert Wood Johnson Foundation, and I will turn it just a second to our program officer, Andrea Dukas, who has both been with this team from the very, very outset of designing the Delta Center initiative a number of years ago and seeing the promise of it and the prospect of continuing it for a second phase. And with that, I will turn it to Andrea.
Hi, thanks, Rachel, and hi everyone. Welcome. It was so nice. You know, there's very little, I guess, has changed in the webinar space in terms of the work from home, right? So I was just reflecting on the fact that typically I would just be doing this in my office. But a nice thing about it is we're learning all of these practices from in-person meetings that have transitioned online. And I loved the introductions and what people were hoping for and the music. So it was just a pleasure to be able to come into this space that way. Welcome. I'm Andrea Dukas, as Rachel said. I'm a senior program officer at the Robert Wood Johnson Foundation, where I work with a team of folks that is very focused on helping to transform the health and healthcare system so that they're aligned with public health, social services, community-based organizations, really in the service of providing whole person integrated care that meets the needs of people and the communities that they live in. We were thrilled several years ago to be able to make our initial investment in the Delta Center. And one of the things, you know, we went into that with the end goal of helping to support safety net providers in the transition to value-based care. Well, what we learned through that process was just how much of a real appetite there was for doing that kind of work together across primary care and behavioral health. And we learned through that process how important it was to not only pursue practice change, but also policy change in tandem, which is why it's been so critical for us to work with state associations. I think our first foray into the Delta Center was very successful. We learned a lot about what worked very well and a lot about what we might improve. And at the same time, we went through a transition that I think many organizations are going through now internally, where we really wanted to anchor ourselves in doing this work in the service of health equity. And as much as we can, really making sure that the work that we're doing, the work that associations will be doing with the Delta Center, is not only done in the service of advancing goals of providers, but making sure that those goals of providers are aligned with the goals of the patients and that they're serving in the communities that they work in. So it's a little bit of a shift, a little bit of an evolution for the program this year, but we're excited to see where it goes. And it's just wonderful to see how much of an interest there is in the second cohort, and I can't wait to meet you all.
Wonderful. Thank you, Andrea. And I'm going to do the sort of Zoom baton pass to Frankie Berger, the Director of State Policy and Advocacy for National Council for Behavioral Health. Hi,
Thank
Frankie.
you so much. Hi, everybody. My name is Frankie Berger, and I direct state policy for the National Council for Behavioral Health. And I've had the pleasure of being on the Delta Center team now for about a year. And I found that from where we sit at National Council, one of the most important things that this program has allowed us to do is build these strong relationships with our partner organization at NAC. And so we've really seen firsthand the benefits of working closely with our primary care counterparts. The National Council team is truly looking forward to working with a strong new cohort of behavioral health and primary care teams, because states are going to be rising to advance value-based programs and meet these new challenges in the safety net. And right now, we know that this work is going to be more important than ever during a time when states are grappling with difficult budget scenarios, and we see the need for behavioral health care skyrocketing. And so, with that, and I do want to say too that we're so grateful that the Robert Wood Johnson Foundation has really made a true commitment to not only hearing patient and consumer voice, but they're really dedicated to meaningfully turning that voice into action across all of their projects, including the Delta Center. And so we look forward to working with a new cohort of you all and advancing value-based payments and being there with our consumer friends. And so thank you. And with that, I'll turn it over to my colleague at NAC.
Hey, Jeremy. Jeremy
Hey there.
Crandall, Director of State Affairs at NAC.
Thank you, Rachel, and thank you, Frankie. Good morning, good afternoon. Jeremy Crandall, Director of State Affairs for NAC. Really excited to be chatting with you all to continue our work supporting these great projects. I am a relative newbie to the Delta Center compared to a lot of the other folks on here, but myself and Gabby Granata, who's also listening in, we're going to be the leads on the NAC side. And so looking forward to really following up on some pretty incredible work that was done in phase one, reducing policy barriers, in providing strategic support for behavioral health integration, stronger payment protections, value-based payment models, and even Medicaid expansion, which is obviously a big one to say last. But I can tell you from an NAC perspective, we're always looking for better and new and better ways, more effective ways to support state level policy efforts at the national level. I come from the state policy world. I worked in the Maryland legislature for about 8 years. So I know how important and how hard on a day-to-day basis the work that you all do is. As we look to 2021, many legislatures and administrations will be meeting remotely or otherwise differently. So your efforts are going to get even tougher and more challenging. I will say it's frustrating that it took a global pandemic to continue to raise the awareness of addressing behavioral health issues to the level that it deserves. While it is an overused phrase, I do think there is an opportunity in this crisis period. We at NAC, we're doing a lot of work on in the telehealth space right now. And our health centers, just like every provider, took a huge hit when utilization dropped in the early months of COVID. But one of the shining bright spots was, of course, the expansion of telehealth services, but even more importantly was the immense growth in behavioral health care services. There was a Commonwealth report that we saw just recently that found across all providers, it was behavioral health that saw the biggest increase in terms of percentage of telehealth visits. So obviously we got a long way to go, but we are always looking to do more, and that's really what we're looking to do with this phase two, is support you all in this very exciting work ahead. So thank you for a couple of minutes of your time here. And Rachel, do I turn it back over to you?
Yeah, I'll take the baton. Thank you, Jeremy. Thank you, Frankie. And I will say, in our first go round of the Delta Center, it was heartening to both have novel collaboration at the national level between National Council and NAC being modeled, honestly, at the same time as state associations were working together, building relationships and working towards collective actions together at the same time. So we were very much hoping to continue that and build upon it in phase two. So let's turn to the next slide. I'm going to start with a broad overview of the Delta Center in general, and then dive into the specifics of this funding opportunity. So I'd love to start with the name. We actually did choose the Delta Center name very consciously 3 to 4 years ago. And we chose it for the following reasons. First of all, we chose it because it actually means change. And we were genuinely looking for change in both policy and practice we recognized and had heard from much research that both JSI and McCall and NAC, National Council, had done over the course of years, that change in practice must be supported with change in payment and policy, and simultaneously change in policy or payment has to be done with the intent and the execution of ensuring that change happens on the ground for providers, for patients, for consumers, in terms of access, in terms of quality of care, in terms of ultimately outcomes that individuals are experiencing. We also chose the name because Delta connotes confluence. Like the picture on the slide, it was in many states a new thing for the state associations to come together to work on, at first, building relationships and understanding, including an understanding of one another's histories, in terms of how they got to where they are as a behavioral health system, as a primary care and community health center system. But it was also about a confluence of ideas. And part of what we are trying to do is bring people together in a space, obviously right now that is going to be a virtual space, but over the course of the next 2.25 years, by the time the grant starts in March of 2021, we do hope that that confluence will also be something that happens in a physical space as well for peer sharing. There's nothing like hearing from others in similar shoes about how they exactly engaged their Medicaid agency or how they made a case for integrated care and payment to their Medicaid director, and to be able to share some of those obstacles, some of those successes in whether it's a Zoom room or a conference room table, to actually really get the full story and have that learning be experiential. We also chose Delta because we are genuinely hoping that the Delta Center will be transformational, both in terms of the relationships that happen, and in this case, in terms of the practices. I talked about equity being both an outcome, but also a process. We absolutely recognize that the community health center movement has been a movement that has long and systematically honored consumer voice by having 51% consumer boards at FQHCs, and that the community-based behavioral health organizations have long engaged their consumers in shaping care and indeed policy at the state and national levels. And at the same time, we are going to continue to challenge this group to think about that and to continue to evolve in that practice, especially by applying a racial equity lens. This year, but certainly building on 400 years of United States history, we have recognized that we cannot turn a blind eye to the racial disparities that persist in this country and the need to do something transformationally different about the way communities are engaged in deciding what is placed at the top of agendas, as well as continuing to work towards full accountability for equity and outcomes. And while I don't have a picture of the pyramids, or maybe I do have a picture of the pyramids at Giza, deltas make history, whether it's the Nile or whether it's the space where rivers have come together over the course of time to bring people together, to bring ideas together. They genuinely can change the course of history. And while that sounds like a big ask for a $240,000 2.25-year grant, we also want you to aim high and believe that these associations have the prospect of truly changing the course of history in their states, and by working with the national team at the national level as well. So that's what's in a name. That's how we got to the Delta Center originally, and we hope that that name will continue to be honored in this grant opportunity. Let's move to the next slide. So just to give you a quick overview of what happened the last time, we did do a 2-year grant opportunity for 12 states between 2018 and 2020. And you can see the states there on the map. We actually had one difference from last time to this time in that it was a encouragement, but not a requirement that PCAs and BHSAs apply together the last time. And so while we had most primary care associations and behavioral health state associations apply as what we call dyads or pairs, there were a couple that applied singly. That is something that is going to be different this time. We are asking, based on the experience and advice of our Delta Center Phase 1 participants, that there is really a richness in working together. And there is great possibility in working together, especially in the eyes of payers and state Medicaid agencies. So that is one thing that is different. I will say that across these 12 states, the projects that they engaged in were varied, but included working in a number of different policy and regulatory areas, from payment reform to, as Jeremy mentioned, helping to advance Medicaid expansion or design new care and payment models in their states that ultimately had the goal of integrating primary care and behavioral health care. We will also say that through the state efforts, we continued to listen about what learnings were happening that could be promulgated to the nation. So as the Delta Center program team, both last time and this time, we will continue to generate case studies, briefs, white papers, and post them on the Delta Center website, as well as continuing to curate content from other initiatives or other research that can help primary care and behavioral health as they collaborate together. We certainly heard from our participants the last time that the amount of stuff out there on the internet and through conferences can be overwhelming. And so one of our goals is to create sort of a best of the best library of sorts that is not the entire world of resources, but is a curated set that can be helpful when you are looking for specific examples of how have other states done this, or what have been some of the hurdles, or what have been some of the successful models that others have run into. So we certainly invite you, whether or not you decide to apply for this opportunity, to visit the Delta Center website as a place where we have treated it as a confluence of ideas and stories and case studies that can be hopefully beneficial to state associations as they are working on care and payment and policy change together. Okay, next slide. Thank you. So the big objectives of Delta Center Phase 2 are on the slide that you see, but they are essentially threefold. The first is to build knowledge and ability of state associations to ensure that the changes in incentives and care systems meet the goals and needs of individuals and families. So this is where we know that you are doing this now, and we have heard and learned from our first cohort of states that it is absolutely helpful to continue to evolve and to continue to learn from one another on how to do this better. And as I mentioned before, especially in a way that involves consumers and involves a racial equity lens in particular, in a new way. Our second objective is to foster collaboration between primary care and behavioral health at the state level. There are innumerable stories of primary care and behavioral health state associations actually saying, we hadn't really known each other before we did the Delta Center. And now we speak with each other more casually, more easily, and it has borne results in terms of how coordinated we look when we are speaking with our legislatures, when we are approaching our Medicaid agency, that they know that people Medicaid beneficiaries or consumers are whole person needs of both physical and behavioral health. And it's delightful when a Medicaid director can hear that the providers and the provider associations are in fact thinking that way too, so that that collaboration starts as a relationship, but ultimately can really be a strategy for engaging effectively on policy, payment, and care change as well. And then, as I just mentioned, our third goal as a program office is to continue to elevate insights for the field, both at the state and the national level, and hopefully to share those with decision makers that are ultimately influencing systems change, both in Delta Center grantee states and beyond. And as I mentioned before, but will continue to be our beacon and our guiding vision, is that the ultimate goal is to cultivate health policy and a care system that is both more equitable in terms of both process and outcomes, and better meets the needs of individuals and families. So with those as our guiding objectives, can I ask for the next slide, please? This is sort of a mini logic model or simplified logic model of how we will get to those. That we understand that building relationships is a foundational part and is a necessary starting point, but that through bringing folks together, that grantees will both learn and grow. And then finally, and perhaps most importantly, we are asking that you together plan and take collective action in the form of a project that has specific outcomes that you are aiming for and specific activities and actions that you will take over the course of 2 years and 3 months. And we will help you to share. We will help to facilitate that sharing of information, experience with each other, and then also with the field. And I've gone over both this outcome and the impact a number of times, so I'm going to ask that we keep moving. But this gives you just a slight sense. And if you don't want to take it from me, I'm going to ask that we play a short video of some of our grantees from the Delta Center Phase 1 for you now.
If we work together, we can accomplish a lot more.
The goal is to really transform the payment methodology so that we're really investing our healthcare dollars in good outcomes.
There is an enormous amount of complexity in doing this work.
One entity can't understand and address all of the dynamics.
Creating those kind of foundational understandings can really help to bring people together more.
To move forward with value-based payment and better, more meaningful integrated care.
It's good to have partners that can have your back and that you can think through things with together. We're stronger together.
And that kind of collaboration really eliminated a lot of the barriers that used to exist. So that also makes a really big difference in our state and overall, and for the health of the individuals we're serving.
We were able to develop a common mission, a common goal, 100% buy-in from our group.
Delta Center, it has propelled that work forward.
Okay, well, thank you, first of all, to all of our prior grantees for their words. And I'm going to now dive into the actual funding opportunity overview. So what is this and what are the due dates? First, let's move to the next slide. Our goal over the next few months is to invite proposals that will ultimately result in grants to 8 grants to joint state association teams that are comprised of a PCA, a BHSA, and possibly another partner representing a consumer group, if you feel that in your state that is the best way to honor this goal of involving consumer voice in shaping policy agendas, shaping care and outcomes. But want to give you that latitude that that is not a requirement, but it is a requirement that involving consumer voice is very much built into every aspect of the project. I mentioned this before, but in terms of the funding amount, the total amount per team is $240,000 over the course of 2.25 years. There is not a requirement that that money be spent precisely evenly between the teams, but there is absolutely an expectation that there will be a evidence in the budget of a fair and equitable partnership between the two associations. In terms of the learning opportunities, we are planning over the course of those 2.25 years 4 total convenings. One will obviously be, and most certainly be, a virtual one in 2021. We currently have slated 3 additional convenings in 2022 and 2023. And at least at this point, we are hoping that they will be able to be in person, vaccine, etc., providing. But of course, we will adapt as needed to ensure and prioritize health and safety of all participants. There will also be 1 virtual site visit, and this is essentially a recommendation and something we did the last time to Compass Point in Missouri, but to allow state teams to really see how is it happening on the ground? How is care and payment integration working and not working, and getting to ask questions of a team and a place that has actually really done this. And NAC and National Council will be coordinating that virtual site visit to somewhere in the country yet to be determined. There will also be monthly coaching calls. We have 3 experienced coaches that will work with teams to both stay up with how things are going on their project, but also to ensure that they are matched with resources, whether other peers or faculty or other resources that we are familiar with to help them with their projects. There is also an expectation, and this is in the name of fostering novel collaboration between primary care and behavioral health, that over the course of the initiative, the PCA will attend, at least some folks from the PCA will attend a National Council for Behavioral Health annual conference, and vice versa. There is so much rich training content, both in the care and policy and payment spaces at those national conferences, that there was a notion that this could be not only an opportunity to learn together, but to continue to share ideas, and in at least the latter parts of the initiative, perhaps be together in the same place to talk about what they are learning. And then finally, there will be a series of virtual learning events, both facilitated and via webinar or affinity group. I will say that these types of things we will be determining in part by talking with the grantees to ensure that the mechanism that we are using, as well as the content, is adapted and tailored to what grantees most need and want. And the second part that I mentioned before is that all teams will be expected to take collective action. In other words, to come up with a project that they want to do that will both strengthen the partnership between the state associations, that will advance policy, practice, and or payment change in your state, depending on your local environment, that will concretely incorporate consumer voice in both process and ensuring outcome, and advance racial equity, again, all as both potentially a process as well as thinking about measuring racial equity as an outcome that we are working towards as care and policy are changing on the ground. Next slide, please. When folks ask what type of collective action project should we undertake? The answer is we are trying to provide enough latitude that you can listen to your local state stakeholders, consumers included, to advance a policy, payment, and or practice change that makes the most sense in your state. We also want to acknowledge that it will be looked upon most favorably, and this is based on our experience from past teams, when state associations are thinking about policy, payment, and practice in concert. That advancing one without a conception or exactly how it's going to support the other can not be as nearly as effective as when they are advancing the two or the three in concert with one another. In terms of the level of change, we also are allowing some latitude on this, that it could be advancing state level policy or regulatory change. It also could include facilitating local level action. And just to give us one example, there are certainly some state associations the last time that fostered collaboration between FQHCs and CCBHCs in local communities, with the intent of not just establishing that relationship in that community, but to understanding what it takes to build an integrated system of care on the ground level, and then using those lessons for both identifying where are there policy or regulatory barriers that the associations need to address to facilitate that, or where are there TA and training opportunities to better help providers on the ground to collaborate and integrate services going forward. Ultimately, in terms of the intent of the change, we will absolutely be looking for in applications an alignment with the Delta Center goals that we talked about, as well as ensuring that ultimately the end goal is to better meet the concerns and needs of patients, consumers, and families that are served by safety net providers. Using both an increased and perhaps differential level of consumer involvement, as well as thinking about racial equity as both a process and an outcome of the project. I'm not going to go through every detail of these, but folks did ask for what would potential example projects that meet these criteria look like. These are by no means the only types of projects that might come about, but it can give you a small sense that advancing policy and payment for peer support might think about putting together a policy agenda that allows both primary care and behavioral health to be able to reimburse peers on the behavioral health side, community health workers on the primary care side, in order to ultimately both advance economic opportunity in the consumers that in the communities that their providers serve, but also to increase access to care through those types of providers. So that's thinking about sort of on multiple levels, how a policy change can also be very much looked at through a consumer and racial equity lens. Of course, it also has a care lens of improving the care that individuals are receiving from their provider teams. Just as one more example, we know that telehealth, as Jeremy mentioned, is a very hot topic right now. And there are multiple associations already thinking about how to cement policy for telehealth reimbursement and payment. But a project might be to think not just about an already extant policy agenda, but to think about it in terms of how telehealth can really increase integrated care and acknowledge where telehealth is working and not working for some populations that might have historically been experienced the most barriers to accessing services so that could be another potential example of thinking about how the care, what exactly needs to happen on the care side, even as payment supports telehealth services going into the future, and doing so in concert as primary care and behavioral health together. So those are a couple of quick examples. Let's move to the next slide. These are just some specific questions, and a deep thanks to Amber Hewitt and Sandra Wilkness at Families USA for sort of outlining what does it mean to center racial equity and consumer voice in a project. Certain questions to consider can include, what does the process of decision-making look like? Who's there? Who's being listened to? How is power being shared? It can also involve really looking at what structures are being focused on to advance equity. Is it just in the care system? Is it in communication systems? Is it in provider training? Like, what is actually being changed that will beget different outcomes than the ones that we have today, which almost universally across every state show rampant and unacceptable racial disparities in both process measures and outcome measures. And then finally, is there a disparate impact? Asking on particular communities, and what are the underlying resource inequities that have contributed to that disparity? And how is this project and this change effort actually going to think about those historical resource inequities, perhaps in a different way? So what might that look like in terms of sample actions? It could look like collaborating differentially with people of color-led advocacy groups to actually develop a policy agenda, or to decide which parts of a policy agenda are being prioritized over others. It might also mean conducting a formal assessment in terms of asking whether a specific payment reform is perhaps inadvertently going to reduce or intensify health inequities, and doing that, asking that question, that real inquisitive question asking alongside or in concert with people of color-led advocacy groups. Okay, so in terms of who can apply and what are the specific expectations, first, I think we have mentioned some of these already, but both partners do need to be affiliated with their respective national organization, be it NAC on the primary care side or National Council on the Behavioral Health State Association side. It's also essential that the application has both a PCA and a BHSA as partners. It does not matter who is the lead entity. We want you to think about who, in terms of various skills and capacities, makes the most sense to lead as the lead applicant and sort of the grant administrator. It is absolutely fair, because every team will have both. We are not saying that there has to be a PCA or has to be a BHSA as the one who's turning in the grant or who is administrating the funds. What is important, as I mentioned before, is that there is a close collaboration that is demonstrated through both the project activities and the budget. And then finally, that you need to be in a location, meaning in a state, where there is at least some level of activity and commitment from the state to support your initiatives. And we will ask you to explain your local environment, at least briefly, in terms of what you are building on, what you are taking advantage of or leveraging in your local environment in terms of Medicaid agency, managed care plans, state mental health funding and financing opportunities that might be available. Next slide. Okay, so what we are looking for. So this is like what would differentiate one application from another. Obviously, we are looking for real, authentic partnership that is beyond where you are today. As I mentioned before, this might mean bringing in other partners, whether it's a state consumer group or other advocacy groups in your state. We will leave that up to you, but we want to make sure that both in the activities and in terms of who is on the team, that there is a balance and a strength of the partnership that is demonstrated in both the plan and the budget. In terms of the plan, we do want to make sure that your project plan both has concrete outcomes and milestones and deliverables, and that it also is concretely thinking about how you will meaningfully address racial equity and incorporate consumer voice in the design and the execution of your project. In terms of this commitment to sharing, as I mentioned, part of what Robert Wood Johnson Foundation is doing is ultimately catalyzing change for the safety net in general and for the field. And we are trying to help do that by ensuring we can share what is going on for you as grantees, including challenges and best practices that might emerge through our peer-to-peer sharing sessions, through coaching, etc. There is also a series of program evaluation steps at baseline, midpoint, and endpoint that will be required for all grantees to participate in. And then finally, in terms of appropriate staffing, what we mean by this is that there really is protected time and a dedicated team to participate in the learning activities and to ensure that your work, your proposed plan is going to be able to be executed. In terms of what you will get, certainly in our past will not exactly be prologue, since we were able to bring people together for all convenings last time. But as I said, we will be bringing folks together to learn content and to do peer-to-peer sharing at least 4 times through the life of the grant. Certainly once once virtually, and hopefully 3 times in person, but to be determined. That there will be concrete content around how folks are advancing both payment policy and practice change in their states. You will get monthly coaching, and ultimately, from the experience of our last cohort, you will absolutely leave with strengthened relationships, hopefully not only with each other, but with a team of 8 other states. And I will note that because this is a second cohort, we have made a small grant to 8 alumni from the first cohort that will also be available to share some of their learnings, at least through the first year of the grant. So that is another opportunity for peer-to-peer learning. I'm not going to go through this, but this is just an example of one of our virtual convenings at the end of cohort 1 in terms of what folks found were the most valuable policy and practice changes and what it was going to take to really sustain those as time went on. This is available on the website if anyone wants to dive into this record. So this is the rough timeline that is in the CFP, just to give you a sense of when critical dates are. I will say once again that one of the goals with those NAC and National Council annual conferences is meant to be a cross-fertilization learning opportunity. There will be a small, think 1 session in terms of actually having Delta Center grantees come together to share and learn together. But in case you are talking to folks from the cohort 1, in last time we had a whole extra day, and that was something that folks said, this is already a big piece of time that we are taking out of our schedule, and we have so much content that we are able to learn at these national conferences. Let's focus there and then do a smaller sharing opportunity for the Delta Center grantees. So that's what we will be doing in this next go round. In terms of the RFP process, the date, we have another slide of the detailed dates. So here's how to apply if you are interested. first of all, and this is just an ask from our team to yours, to let us know via email that you intend to apply by December 18th. This is a simple email. It is not binding. If things change, it's okay, but we would really like to just get a sense so that we make sure we have allocated the right amount of time for reviewing applications, that you let us know that you plan to apply. The due date for the proposals is January 8th. We hope that that allows enough time before the sort of holiday end of the year and in the beginning of the year to allow you to develop your proposal. All of this information, as well as submission links, are available at the website address listed below. And we will certainly send these slides out and have them posted on the website for anybody who has not been able to attend. In terms of proposal, it's 10 pages. We do ask that as an appendix that you include a letter of commitment from the partner association, as well as any other associations or groups that you might be involving in your project. And when we say a letter of support from a key stakeholder, this could be a provider, it could be a state Medicaid director, it could be a managed care plan executive that you plan to work with on a specific payment reform. We do want to make sure that that is a wide enough latitude of an expectation that it makes sense given the project that you are choosing to pursue. We also ask for resumes of the proposed team and a budget narrative and filling out the budget form. We've tried to make these fairly simple and to pass down essentially just the most easy to understand concrete directions that we have from RWJ about indirect costs and how to report things like direct and indirect costs. And then this is the timeline. I did mention before that sort of from right now until December 11th, we will have a Q&A period. The questions can be submitted via the Delta Center address, the email address, and that is at the end of this slide presentation. I already mentioned a very short non-binding letter of intent to apply by December 18th, a full proposal by January 8th, and depending on whether we need to or not, there may be interviews of finalists in the final week of January, and you should expect to hear back from us by February 2nd for a March 1st start date, ending 2 years and a quarter later in June of 2023. And with that, we have about 6 minutes for questions. If we don't get to your question, we will absolutely invite you to send them to us, and we will make sure that we answer them before or after we've received all questions in December. And those will be posted on the Delta Center website. Okay, I'm gonna see if I can check right here as I see them, but I also will ask my lovely team, Tracy and Jen and others, to elevate those that I may have missed. Do you want to feed them directly to me? Hi, Tracy.
Hi, Rachel. So yeah, as Rachel mentioned, please email us at deltacenter@jsi.com with any questions. We'll be posting an FAQ on the website at deltacenter.jsi.com/CFP. So there are quite a few questions, and we can start with one on types of projects, Rachel. So the question is, would working to implement CCBHCs in the state be a project that would be acceptable?
I think yes, as long as there is a clear demonstration of why it makes sense for that to be a joint project for PCA and the BHSA to be working together on. I do know that there are certainly some states where CCBHCs that have been awarded are actually also FQHCs. So I think particularly in a case like that, that would make a tremendous amount of sense to be thinking along those lines. But I think that as long as you can explain like how the requirements of involving consumer voice, making sure you're taking a racial equity lens in terms of both process and outcome, that would be a very acceptable project.
There's a question on who can apply. Does the partnership have to include a PCA and the state level behavioral health organization, or can it be a PCA and a behavioral health consumer group?
I think that at minimum, there needs to be at least a PCA and a state level behavioral health organization. It can also include a consumer group, but at minimum needs to include PCA and Behavioral Health State Association.
Another question, would a large behavioral health IPA representing over 60 behavioral health agencies in a large city be eligible to apply? We are a state nonprofit organization that represents safety net providers.
I'm going to see if Frankie wants to field that from National Council.
And if I can just add for both Frankie and Jeremy, a subsequent question about what category of membership in the national associations is required.
I had sent that question, this is Frankie, to JSI because I didn't know what our take was on that. So maybe we have to revisit that as a group. I would think that if they are a member of the National Council or NAC and they serve the functional purpose of being an association that is working with safety net providers, and that's something that we could certainly consider, is my initial thought on this.
Yeah, thank you. And sorry to put you on the spot there, Frankie.
No,
for those on the webinar, we will take this one and we will make sure that there is a clear written answer that comes out. But this is why we have the questions where we had not thought of that specifically. So thank you for elevating that question. Oops, Tracy, you're
This is a similar question about if the funding can be shared among 3 organizations. This in particular is talking about behavioral health primary care and the Family-Based Care Association.
Yes. Yes, that is totally fair.
Let me just track my questions, but just another ask if you have any additional questions to go ahead and drop them in the chat. Okay, this is a question, and we have just about a minute left. Inequities in care for substance use disorder and mental health are significant for the LGBTQ community. Although the guidelines say racial inequities, are proposals to address LGBTQ access appropriate?
I would say we would absolutely not discount or discard a proposal that was striving to address inequities on behalf of LGBTQ or other groups. I mean, obviously there are also serious inequities in behavioral health, people who suffer from serious mental illness and those who don't. There are absolutely many inequities that would be, honored and important, and we would consider as, an important way of addressing inequities in the proposal. I think that to our earlier point, that we would also ask you, sort of in addition to that, to take an intersectional lens and acknowledge that racial inequity on top of other inequities is something that this nation absolutely has to continue to reckon with. So not instead of, but in addition to, is how I would answer that.
And I think we're at time, Rachel, so if you can wrap us up. Again, additional questions can be sent to deltacenter@jsi.com during the Q&A period, which runs to December 11th. We'll post slides, recording, and FAQ to deltacenter.jsi.com/CFP. Looking forward to having you all join us. Thank you.
Yeah, thanks everybody.